Welcome to the final section of basic arrhythmia and advanced arrhythmia. We'll be talking about pacemakers. Thus far through the course, we've talked about native pacemakers, and those are the organic ones. The cells themselves, the heart that you were born with, and those parts that can generate an impulse on their own to create a heartbeat. With this part, this last section, we're going to talk about the artificial pacemaker, or pacemakers, the ones that are implanted by the healthcare industry. So we'll talk about those in various ways. For the basic arrhythmia group, the focuses I have for you guys is going to be the terminology, common rhythms, and by common rhythms, you can almost think of that as common functions of pacemakers, things like being atrial paced, ventricular paced, AV paced. In some cases, patients have demand pacemakers where their underlying rhythm is okay most of the time, but occasionally that pacemaker needs to kick in to help make up the difference. So we'll talk a lot about those, and then there's a few other specialty items I do at least want to touch on, because this is a great place to talk about those and make you aware of some finer points on taking care of pacemaker patients and what to do in case of emergencies. As for the advanced arrhythmia group, it really is just diving deeper into each one of these items. Some extra terminology, the functions, and more importantly, the malfunctions. For both groups, you'll find that reading strips for pacemakers is very easy. You just look at it and you can pretty much tell right away almost, except when it comes to the malfunctioning and when they're not doing the job they're supposed to. At that point, they can get really complicated really quick, and hopefully I'll give you the remaining tools you need to be able to dig through that and figure out what's going on, or at least have a good idea so that when you're communicating with the cardiologist, you can get the job done quickly. And here we go. Beginning with terminology, the inherent pacemaker or native pacemaker is the one you're born with, or any other part of your heart that can generate an impulse. Artificial pacemakers are devices that we implant to artificially stimulate the heart and cause depolarization. And that's the big trick. It's an artificial electrical impulse that causes the depolarization. And as we go forward, you'll see that there's a spike, which is the artificial part, and then the depolarization. So you should see a QRS or something like that. We'll get plenty of practice with that part. The goal of all of this is to maintain an adequate heart rate. And in fact, that's the indication for placing a pacemaker pretty much all the time, almost. It's the idea that once it's been established that the patient has a bradycardia, and that's the big one. Once we know for certain that the patient has a bradycardia or a conduction disorder that warrants permanent pacemaking, the cardiologist will then determine what the most appropriate pacing device and mode is for that patient. And it really is just up to the MD, and it has to be tailored with every case. Other terms that are important to know, when we talk about the generator, that's actually the battery portion, what provides the electricity. The conducting wire is what carries the electricity to the inside of the heart, so an electrode, and then the return wire completes the circuit, because it's just like a light switch. You have to have a wire going in and a wire coming out. The more common types of pacemakers we run into can be divided into two categories. You have the permanent pacemakers, which is what most people think about when you hear one. Grandma or grandpa's got a pacemaker now. These are ones that are actually implanted. It goes underneath the skin, and the wire, as you can see here, actually goes through the subclavian vein, superior vena cava, and actually terminates inside the right ventricle. And that's the most simple and pretty much most common version that we talk about when a person gets a pacemaker. It gets more complicated from there, but we'll just start with this for now. This one here is long-term. For years. In fact, my grandmother got her first one when she was 80. She actually went through 3 generators. She used up that many batteries. She had a pacemaker for over 14 years. So that just kind of indicates what kind of time frame we're looking at when we try and do permanent pacemakers. Now, on the other side, we have our temporary pacemakers, and there's 2 subsets for that. The one that you've probably seen or heard the most about is going to be your transcutaneous. And this is essentially the pads. So all of these lectures prior, when I talk about the bradycardic patients and you put on the pads, that's what I'm talking about. There's actually 2 flat stickers that you put on the front and back of your patient, or however the picture on the sticker says to place it. And that's what conducts electricity. The electricity goes through one electrode and comes out the other and runs it through the heart, causing it to contract. They hurt, by the way, so make sure you medicate, because it's like grabbing a hot fence, if for those farm kids who may have done that in the past. So keep that in mind with pads. They hurt when we use that to generate a heart rhythm, a heartbeat. The other version is going to be your transvenous, and this one actually requires central venous access. So it usually goes through a sheath or something like that, and it actually follows that same path that it goes through here and ends in the right ventricle. You'll notice how this long wire then has a box here. There's actually an external wire and an external box that sit next to the patient while this is running. And that's that thing that really points out that it is temporary. Hopefully only a few hours, not more than a day if you're lucky, that we have to use that one. So this one here uses a wire. So temporary pacemaker, transvenous, that uses a wire. Transcutaneous, that uses the pads. And then permanent pacemakers are implanted under the skin and are there for years and years. As a final bit of comparison, I don't want to forget to mention this. The pads, they hurt a bunch, but with the temporary, because that wire is inside the right ventricle, there's no pain associated with it at all. And that's actually something that gives it an advantage. So the transcutaneous is like the true emergency, where you don't have time to do more than just put pads on. The next step to that would be the transvenous, when there's a little bit more time to put it in, but it's still technically emergent. And then finally your permanent, that's more of a planned situation there. Providing some specific examples to help clarify what I've just been talking about. The pacemakers are divided into 2 major categories: single chamber pacemakers versus dual chamber pacemakers. In the single chamber pacemaker group, they stimulate either the atria or the ventricles, but not both of them. And so the way those would be classified might be something like AAI, where it senses the atria, paces the atria, and inhibits if the patient manages to produce their own native rhythm. Another version of that would be something like VVI, which is those temporary pacemakers, sense the ventricle, pace the ventricle, but inhibit if the patient manages to kick something out. The other side of it would be the dual chamber pacemakers. And in that case, it actually is capable of stimulating both the atria and the ventricles. And this is really, really cool because it allows us to do something called AV synchronous pacing. An example of that would be DDI, and you can go back to the previous slide to look at that classification closer. But the idea is that you maintain cadence between the atria and the ventricles, so that the pacemaker is completely in control, and it says, I pace the atria now, and then after an appropriate amount of time, I pace the ventricle to, again, artificially create an appropriate heart rate, heart rhythm, things of that nature. Another higher end version would be the biventricular pacemaker, which would be something like DDVI, where it not only paces and senses the atria, but is also capable of doing the right and left ventricle independently. For the advanced arrhythmia group, we'll go over that in greater detail. To just give you the quick preview of it, it's something called CRT is the type of therapy that is, and that stands for cardiac resynchronization therapy. Advanced arrhythmia, we'll dig into that more. Here we have an example of a patient who has underlying atrial fibrillation. And that's what these center beats here, C, D, and E, represent. That's the AFib. This patient also has demand V pacing. And that's what you see here. So these beats here, A, B, and F, are all paced beats, specifically ventricular paced. You can tell for two different reasons. One, you get this pacemaker spike here. And this spike is the electricity being picked up. So generator sends a spike, the EKG is able to see that little spike, and that's what it looks like on the monitor. And then the spike creates this large, it looks like a PVC, doesn't it? Well, that's how you can tell that they're V-paced, is because you have a spike, and then that causes the ventricles to conduct in the same way that a PVC would conduct. And that's good enough, because without this pacemaker, the patient might be dead. Another example of pacing, this is atrial paced. And so in this case, you can see the pacer spikes right in front of each P wave. And that's followed by a normal QRS. And that's just the idea, is that this is an A-paced patient. Or you could say, 100% A-paced. It's not terribly complicated to look at. You just, do you see the spikes? Is there a response from the heart? In this case, we're looking at P waves. And because the spike is in front of a P wave, that tells you it's atrial. In that previous example, the spike caused a large QRS. That tells you it's ventricular. This is an example of someone that is AV synchronous paced, or AV paced. And the whole idea is this, that you have two spikes here, don't you? Each heartbeat has two of them. And what's happening? You have the first spike, which gives you your P wave, and then you have a second spike, which gives you your QRS. And that's, you've got your atrial and ventricular, atrial and ventricular. So that's where the AV comes from. The synchronous means that the machine actually determines the timing of, when the first beat happens and then when the second beat happens. So this patient is definitely dependent. I know I spelled that wrong, sorry. Is dependent on their pacemaker. So without it, they may have no heartbeat whatsoever. So we've talked about loss of capture, failure to sense, runaway pacemaker. What are you really supposed to do, though, if your patient winds up presenting with these problems or developing them while they're under your care? Well, ultimately, it's, care for the patient first. Focus on the symptoms as best as possible and try and treat those. If they've got low cardiac output, so they've got that low blood pressure, they feel the palpitations, the anxiety, try and do the little things you can to try and get them through it. If you know that there's been a rhythm change, the underlying rhythm, that may be part of the problem. If their rhythm changed to something new, That could have been the cause for why we're having these new malfunctions. Ultimately, when a pacemaker does malfunction, treatment is directed at the patient and the underlying rhythm. If you think about it, pacemakers are the treatment. They wouldn't have a pacemaker in place if they didn't already have something pre-existing wrong. So if they've got a severe bradycardia, we gave them a pacemaker as the treatment. Now if they have a new problem, we need to do whatever we can for that scenario and not make, oh, it's a pacemaker is broke, let's fix that first. So try and keep that in mind, focus on the patient, take care of them, and then as you go forward in that patient's care, then they'll be able to dig in and figure out if the pacemaker needs any kind of adjustments. So as you're at the bedside caring for the patient, try and notify as quickly as possible or immediately, if it's truly an emergency, the cardiologist or an ER provider, either one, depending on what your scenario is, to come and evaluate this patient and see what they can do to try and figure out what's going on. These are the ones that will decide if the pacemaker is responsible. And that's up to them. That's not, the bedside care provider's job, the nurse or whoever. It's up to those guys because that's where their training lies. That's part of their job. Another great source of information and someone you may want to contact at the same time or at the behest of whoever the physician is caring for the patient is the pacemaker reps. They are a great source of information. Even if you just have questions, I've always had great experiences contacting them about patients and their pacemaker function. The patient should have a card on them. And that card's going to say what brand it is. And it may even say what function that the card has been placed under. Or, sorry, the card should say at least what brand of pacemaker the patient has and potentially the functions that were set up on it so that you can have a better idea of what's going on. If you don't have access to the card or if the patient's just presented unconscious and you're just trying to do what you can, check out the EMR. That's an excellent source. Or an excellent record of the device, especially if it was placed in your facility. In those cases, the cath labs and places that do this will put in all the information you need to figure out what type of device it is and who to contact in order to expedite things. Ultimately, you're going to anticipate doing the following. Plan on doing an interrogation. And that's going to need to be done by a trained expert. So either the pacemaker rep themselves or another care provider who's been shown what they need to do in order to use the interrogation device to figure out what's going on. That could be cardiologists, whoever. Adjustment, that will definitely be done by the cardiologist. They're the ones who are going to be able to figure out be able to read it and see what settings are best to help correct the problem. I've seen this done at the bedside a handful of times myself, that they'll have the device open, the patient's laying there, they'll hit a couple buttons, see what changes, make the adjustments, and then we'll write it out, see if that's effective or not, and maybe potentially change it again. It just really is a patient by patient scenario. Last but not least, and of course the least ideal scenario, is replacement if needed. If you run into one of those big problems where it's truly broken, either the generator or maybe a lead came loose, things of that nature that require a procedure, don't be surprised if something like that happens. But again, last result, hopefully it never comes to that. I now want to talk about ICD, Implanted Cardioverter Defibrillator. Most of you've probably heard about this or may be familiar with it, but I want to clarify some things. So, the first off, I want to say automatic. And so if you put that in front of there, you have AICD. And essentially the idea is that it's not a pacemaker. It has one job and one job only, and that is to actually defibrillate your patient. It shocks them. Just like in a code blue. You put the pads on them and you zap them, right, to try and get them into a better rhythm. This does that, except it's implanted and automatic. It actually is reading the heart constantly, and then if it senses the appropriate parameters, goes, all right, let's get to it, and zaps them. So AICD, some people, in fact myself even, call it implanted cardiac defibrillator. That's probably a misnomer, but it's just one of those things that people tend to say. But AICD, what the heck is it? Why do we do it? Well, I explained what it is. It shocks patient. It defibrillates them into a better rhythm. Why do they get them? Well, there's two reasons. There's either secondary prevention or primary prevention. Secondary makes the most sense because it is secondary prevention of SCD, which is sudden cardiac death. And let's be honest, we want a machine that'll help prevent us from suddenly dying. The heart itself. What buys people one of these? What do they have to have in order to qualify? Well, they had to have prior had episodes of VTAC or VFib. One of the common scenarios for that would be post sudden cardiac arrest, and that they coded, and we brought them back. So they had VFib or VTAC. We were able to resuscitate them. They've been resuscitated, and now to prevent that from happening again, we put this on. So that's the one big group. The other group is going to be as a primary prevention. And the primary prevention group is, again, of sudden cardiac death. These are the folks that are at an increased risk of VTAC and VFib. So they have a existing cardiac condition that makes them highly likely to need this kind of treatment in the future. A really common example is going to be heart failure patients, where they've got just poor heart function that is highly likely to lead to this. So in either case, it's VTAC and VFib, either the risk of it or the fact that they've had it before, which proves that they need it. That's how they wind up qualifying. The the most important thing I want to share, and I giggle when I say this because I've had it happen, it hurts. The patients, they can feel it. In fact, I've had cases where a patient, it was malfunctioning and it was firing. Well, I shouldn't say it was malfunctioning. The patient kept going into VTAC because their medications, they weren't taking their meds like they should. And so it fired a handful of times in a single day. And it's like grabbing a hot fence. And so this patient would sit there and he would say, oh, I feel it coming. I feel it coming. The alarms would go off at the bedside, and all of a sudden, zap, and he would shout so loud you could hear it down the hallway. Like I had other nurses coming in the room going, what the heck's going on in here? And it was his defibrillator. Of course, we were waiting for the cardiologist was on their way, and we were making adjustments to try and prevent that from happening. But they could feel it coming. They could feel it when it hit. It is not a fun thing to happen. And so the most important advice I can give you for patients who have an AICD that is going to be firing, and that there's a chance of it, do not hold their hand, because you'll get shocked too. In fact, I had a patient who wound up coding, and we were doing compressions, and it was me and another nurse in there because it had just started happening. He actually went down right in front of me, and I'm doing compressions, and she's there. We just got done boosting him. I'm pushing, and sure enough, I got zapped while I was doing the compressions on him. I kid you not. It didn't hurt. It was, for me at least, but it shows you that that electricity can be conducted throughout the whole body, even though it's a relatively small amount. So those are things to keep in mind with these patients. Ultimately, what does the AICD do, aside from the really fun story I just told you? AICDs have the capability of monitoring. So some patients just have one of those in, and that's all, no pacemaker. And it collects information about the heart. It just records things. It has the ability sometimes to do anti-tachycardia pacing. So if it looks like the patient's going into a really fast rate, it may send out signals to try and correct that. Of course, cardioversion and defibrillation, that's what it's there for. Bradycardia pacing. Now, in this scenario and this scenario, it is entirely possible for a patient to have a pacemaker and AICD. And that's a very, very common thing and an important question to ask, hey, do you just have a pacemaker, or is it capable of, delivering a shock? Sometimes patients know, sometimes they don't. But if you're looking at the records and can figure that out, that's very helpful. And the combination of the two is absolutely excellent for these types of patients who have very poor heart function. Last but not least, and this is for the advanced arrhythmia group, is the cardiac resynchronization therapy. That is a high-end pacemaker that also has the AICD mixed in with it, so that it can deliver the pinnacle of what we're capable of doing for patients with very poor heart function. I've included this strip just because it's rare to catch one of these, so I think it's just neat for you guys to have seen it. This patient's starting out in VTAC over here. That's what this whole mess is. But then right here is where you see the defibrillator go off. And that's what all this is, that really sharp spike in the electricity followed by some recovery time, and then the patient goes back into their normal rhythm, which in this case is being paced, but that's what it looks like on the screen when a defibrillator goes off. Magnets and pacemakers. This is something that I wish had been explained a lot better to me when I had first started my nursing career, and so that's why we're really going to take the extra minute to go over this. Magnets are really important for a lot of different reasons, particularly when it comes to pacemaker patients. Essentially what happens is, just like you see here in the picture, you place the magnet directly over the patient's pacemaker. Or over their ICD. And this is the reason why I'm talking about this right now. When you apply the magnet, it does two different things. If the patient has an ICD, it shuts it off completely. So if you have a patient where the ICD is firing, whether appropriate or otherwise, placing the magnet there turns that off, and the patient will no longer receive those defibrillating shocks, the ones that really hurt. If it's going off a whole bunch and it's not supposed to, you do that to help protect the patient. If it's going off because maybe it's an end-of-life case, that's a great reason to shut it off, because, well, if it's end of life and they're on hospice or something, you don't want them to be shocked if it's unnecessary, because that's not the kind of treatment you want to provide. So those are two important scenarios I want you to kind of keep in mind. But so that's for the ICD. The other thing it does for the pacemaker is it induces asynchronous function in pacemaker. What does asynchronous function mean? Well, I'm going to write that out real quick in green. Asynchronous function is where the sensing is turned off, sensing's turned off, and it paces continuously no matter what. Basically what happens is the pacemaker now no longer looks to see what the patient is doing and just goes ahead and paces all the time no matter what. And that's really cool because if a patient has a pacemaker malfunction where it's firing a whole bunch, like trying to pace the patient really fast, put the magnet on, it slows it down. So now we put these two together. If the patient has a pacemaker and an ICD, it will turn off the ICD but does not shut off the pacemaker. It absolutely doesn't. And I bring this up because I've encountered this scenario before where a patient goes comfort cares. We place the magnet on there to shut off the shocking, the defibrillation feature. And the family assumed that, oh, we're shutting off the pacemaker altogether, and so then the patient their heart should stop and they should pass away soon. That is absolutely not the case. The pacemaker keeps running, and you need to explain that to patients and their families, or I should say, explain it to the family that we cannot turn off the pacemaker using this device. In fact, it brings up some technical and legal sticky situations. And so 3 common scenarios. This isn't all of them, but I just want you to have this thought exercise with me. Is ICD shocks near end of life. That's one. The other one would be pacemaker dependent patients. So you've got a pacemaker, and I talked about the shocks near end of life where, you don't want to be zapping someone when it's unnecessary. Pacemaker dependent patients, someone who their heart would not beat if it were not for the pacemaker. If you shut that off, what did you just do? You turned off their heart. You essentially killed them, for lack of a better phrase. It's like the physician-assisted suicide, that kind of stuff. And that gets really sticky from a legal situation. So we really do just shy away from it altogether. And if the patient has a pacemaker, they're dependent on it. From a hospice standpoint, we keep it running because having a beating heart is kind of looked at as maintaining quality of life. And that person likely has a comorbidity that will be responsible for their demise, ultimately. And the other one is for comfort cares. And in a comfort care scenario, this one we really, really do look at the comorbidities as being a big player here. So let me just read from my notes to make sure I sum this up right. In the comfort care scenario, oftentimes the patient's comorbidities are what has led to the situation where we had to withdraw care. And so an example would be a patient with respiratory failure. And the failure of the lungs will lead to low oxygen in the body and other related problems. That will ultimately cause the patient's demise, and the pacemaker's function will not alter the outcome. And so in those scenarios, we put the magnet on there to keep the ICD from shocking, but then we just leave the pacemaker running because other stuff will ultimately cause them to pass away. In the pacemaker dependent section, you look at hospice scenarios that unless the patient or family has a very, very, very strong desire to discontinue the pacemaker, it's left on for quality of life. And think about it this way. If a patient has bradycardia and they get dizzy and they don't have energy and they look crummy, leaving the pacemaker on there gives them more energy, makes them feel better. And so that's why we'd leave the pacer on. But we'd turn off the ICD because we don't want, they're on hospice. The goal is not to provide a life-saving intervention like defibrillation. And again, back around to the ICD shocks near end of life, they have a profound negative impact on that quality of life, not only for the patient, but for the family that's standing there watching. If you see one of these go off, the whole body shakes, it jerks. If there's any kind of consciousness left in the patient, they shout out. They're in obvious pain. And so turning that off not only helps the patient, but it also helps the family know that their loved one is passing away more peacefully. And that's a good reason to, or one of the many reasons that we do that. Last little bit, just to clarify this while we're on it. Withholding therapy versus withdrawing. Sorry, I got those little bits in there. Sorry. All right, so withholding therapy is the idea that we're not providing something. So that not providing a therapy that may be indicated. So the patient should have this, but we're just not going to give it to them. That's withholding. Withdrawing therapy is where we refer to removal of previous treatment. And, so that we had the ICD and we withdraw that therapy because we don't need to be using that anymore with that patient. And again, as opposed to withholding therapy where it's like this patient really needs X, but we're not going to provide it. So keep in mind, turning off the ICD in these end-of-life scenarios, that's a withdraw of therapy in order to improve either quality of life or in situations where we don't want to affect the outcome. Artificial pacemakers deliver an impulse to the heart via which three methods, or which three types of pacemakers exist? Well, in terms of artificial, we have temporary transcutaneous pads, so that one's correct. We have temporary transvenous wires, that one's correct. Telemetry monitoring wires, well, right there, it says monitoring, so that's not accurate. And then, of course, there's permanent transvenous wires, and that's your classic pacemaker that most people think about. So those are your top items for how we deliver pacemaking to patients. Temporary transvenous wire pacemakers are typically connected to which chamber? And if you go back to the diagram, you can really see what those options are, but it has venous in the title, and so you can kind of check off the left side of the heart because that's more of the arterial side, which then leaves you with right atrium and right ventricle. And if you look at the diagram and how it was explained, that it's not the atrium, it's that ventricle is where most, pretty much all, temporary transvenous wire pacemakers are connected. Placing the donut-shaped magnet over a pacemaker and or ICD causes what to happen? So what does the magnet do? Well, does the magnet turn off the ICD? Absolutely. Does it turn off the pacemaker completely? Absolutely not. It doesn't do that in any way, shape, or form. Does it switch the pacemaker to an asynchronous pacing function? Yes, it does. Do we only use the magnet for interrogation of pacemakers? That's not true. We actually use it for a multitude of things. So that's an inaccurate statement, which then just leaves us with the answer A and C. I'd like to wrap up by just saying a big thank you for sitting through all of this information. I know it's a lot. It can get overwhelming, especially if you try and digest it all at once. But please don't let this discourage you, especially if you really found it interesting. There's so much more to learn, and there's some other versions of this class that I have available that'll give you a deeper breadth of knowledge for all of this. Again, thank yous not only to those that are taking the class now, but also the ones who helped me get here. The monitor techs who've saved strips and asked great questions, the nurses who have done the same. This is truly one of those things that you'll never learn at all. You can always learn more from it. So I will leave you. There's no final test with this. It really is just the quiz work that's along with it within the assignment. So thank you again, and I hope to see you with my other courses.